Welcome to another practice case with MedicoMedics. A 67-year-old man is brought to the emergency department due to acute shortness of breath and orthopnea. He has a history of long-standing hypertension, coronary artery disease, and a prior myocardial infarction. On exam, he is tachypnic and using accessory muscles to breathe. Bibasilar crackles are heard on lung auscultation. His jugular venous pressure is elevated. Chest X-ray shows bilateral perihilar opacities consistent with pulmonary edema. Now, which of the following is the most likely primary mechanism contributing to this patient's condition? Is it increased plasma oncotic pressure, decreased capillary permeability, elevated pulmonary capillary hydrostatic pressure, lymphatic obstruction in the lungs, or decreased alveolar surfactant production? Feel free to pause the video and take a few seconds to see if you can find the answer. If you've selected alternative number 3, elevated pulmonary capillary hydrostatic pressure, then you are correct. See, this patient presents with acute pulmonary edema secondary to left-sided heart failure. This is likely due to ischemic cardiomyopathy. See, in this condition, the left ventricle fails to pump effectively, leading to increased left atrial pressure, which then backs up into the pulmonary circulation, raising pulmonary capillary hydrostatic pressure. Now, why is it not any of the other alternatives? Well, let's take a look at increased plasma oncotic pressure. Well, this would actually draw fluid into capillaries, not out of them. So it would prevent edema, not cause it. See, when hydrostatic pressure exceeds the oncotic pressure of plasma proteins, fluid leaks into the interstitial and alveolar spaces. This impairs gas exchange and then leads to dyspnea and hypoxia. What about decreased capillary permeability? Well, this would reduce edema. See, pulmonary edema from heart failure occurs despite intact capillary membranes. Lymphatic obstruction in the lungs, well, this may contribute to localized interstitial edema, for example in cancer, but not the diffuse alveolar flooding seen here. What about decreased alveolar surfactant production? Well, this is mainly seen in neonatal respiratory distress syndrome, not adult cardiogenic pulmonary edema. Now, you may wonder, and this is slightly more high-yield reasoning, but how can we tell it's secondary to left-sided heart failure? Well, the clues are in the clinical case here. First of all, he has a history of hypertension, and that would explain a left ventricular hypertrophy. Furthermore, he has a prior myocardial infarction, so that would explain systolic dysfunction due to ischemic injury to the left ventricle. Now, these two together gives us a typical picture of left-sided heart failure. But also, the clinical presentation gives us other clues. So he has orthopnea, meaning difficulty breathing when he's lying flat. That's a hallmark symptom in pulmonary congestion, especially seen in left-sided hypertrophy. Furthermore, he's using accessory muscles to breathe. He has crackles, which means there is fluid in the alveoli, meaning pulmonary edema. And finally, chest X-ray. This is showing us bilateral perihilar opacities. That's the classic quote-unquote bat wing or perihilar infiltrates. So, cardiogenic pulmonary edema. So the key here is the combination of both risk factors, the dyspnea, orthopnea, crackles, and the pulmonary edema on imaging all strongly point to left ventricular failure as the initiating event. And now then, let's briefly take a look at the high-yield review here. Feel free to pause and repeat. But just briefly then, the cause, capillary hydrostatic pressure, so cardiogenic. A cardiogenic edema, which is the most common here, we would have left-sided heart failure. So the left ventricle here begins to fail. There is a back pressure to the left atrium, and that would then continue to elevate the pulmonary veins, or the pressure in our pulmonary veins. Eventually, with the buildup of edema, we have dyspnea, orthopnea. We will have the crackles, seen in this example here. Chest x-ray with the bat wing sign, or infiltrates. Diagnoses, of course, chest x-ray. A pulmonary capillary wedge pressure would be elevated in cardiogenic cases. We're dealing with edema, so loop diuretics like furosemide to reduce preload. Important is to treat underlying causes and, of course, prevention. And that's the end of this lecture. If you want more high-yield cases, make sure you like and subscribe. And as always, keep it clinical.